Thank you. I'd like to just mention that it's an honor to present this work on behalf of my colleague, Dr. Sophia Zamudio-Haas, who couldn't attend. So during this presentation, I'll provide some key findings based on qualitative research conducted among methadone clients in Dar es Salaam, as well as service providers. I'll begin with just a brief background on our program, methods, key findings, discussion, and conclusions. In Dar es Salaam, the general city population has an HIV prevalence of approximately 7%. When we compare this to people who inject drugs, HIV prevalence is between 5 to 8 times higher. When we disaggregate the data by gender, HIV prevalence among men who inject drugs is 24%, but more than 2 times higher among women who inject drugs. To address the emerging HIV epidemic in Dar es Salaam and Tanzania, the Ministry of Health and Social Welfare, in coordination with the Drug Control Commission, began planning to implement methadone maintenance in Dar es Salaam. This led to the launch of the first publicly funded methadone clinic on the mainland of sub-Saharan Africa in February of 2011. Briefly, there's 4 community-based organizations that are operated by the Tanzanian AIDS Prevention Program, and they provide street-based outreach. And among those who are interested in enrolling in methadone, they prepare clients through a number of preparatory sessions on HIV, STI education, as well as retention. And then referral from the CBOs is required for those interested in methadone. Routine programmatic monitoring and evaluation have revealed that there are discrepancies or inequities in service utilization between men and women at all points in the continuum of care between outreach and into methadone. In addition, previous research has showed that there are gender differences in HIV risk, mental health, as well as history of abuse. Females that are enrolled in methadone are more likely than their male counterparts to have reported multiple sex partners, have high substance dependence, symptoms of depression or anxiety, and any history of sexual abuse. A grounded theory process guided data collection analysis, and this process is characterized by simultaneous data collection and analysis. From October 2012 to February 2013, 19 in-depth interviews were conducted with male and female methadone clients, and 6 interviews were conducted with service providers. A little bit about the clients that participated in interviews. Females were purposefully sampled to be the majority of the population. Among those who self-reported HIV status, 6 or nearly 46% reported living with HIV among females. In addition, nearly 40% of female participants reported being survivors of sexual abuse and 40% being survivors of physical abuse. Common emerging themes that came out of in-depth interviews included that women who inject drugs use heroin in different and more secluded spaces than men. In addition, many of the women also were sex workers who go to the road at night and sleep all day. This conflicted with the current outreach strategy, which happened during the day and was not reaching women. And lastly, the majority of outreach workers during this study period were male, so many of the spots that they frequented were also male-focused injection locations. From a male peer outreach worker, to get women, we have to go to them where they are available so as to reach them. If we go to places they are available, they do not deny our information. I think the best time is at night for this kind of work. Interview data also pointed to the importance of having sex worker peer outreach workers to engage women in outreach rather than men who are former PWID or living with HIV. Drug use amongst young women or young girls is very hidden in this community, actually by culture and by the way they operate. But sex work is a bit more obvious, but also a lot of silence around it. Meeting with girls can be difficult. In the afternoons, they need rest. In the evenings, they go out. So the best person to work with the girls is somebody from the same group who can be with the girls when the time is appropriate for the girls. Based on interviews and service providers and clients, combined with some direct observations at outreach and service delivery sites, changing outreach strategies is essential to reach more females with harm reduction services. Nighttime outreach would be ideal, as women are more available at night than during the day. In addition, peer outreach workers are needed to approach the women and identify areas where they can be found. The insider knowledge that these women have about hangouts and strategies to approach the girls can help overcome barriers to linking women into care. Since these interviews, the program has trained and employed a number of peer outreach workers, and today approximately 40% of outreach workers are now female. However, outreach at night has not yet begun. Common emerging themes that came out through interviews regarding enrollment, barriers to enrollment and retention in methadone, included double stigma faced by female clients as former sex workers and people who inject drugs. This theme came out repeatedly throughout interviews. And double stigma can affect the linkage and retention in care. Additional common barriers expressed by female PWID included limited job opportunities for women once in treatment, and the lack of finances to get to and from the clinic every day. Discrimination and intimidation from male counterparts at the clinic was also reported, as well as perceived stigma on the larger hospital grounds. In this quote, the woman notes that women experience greater discrimination than their male counterparts, which she connects to a general lack of support and work opportunities. In DAR, a woman who does drugs is more vehemently discriminated against than a man who does drugs, because she is a woman. A man who does drugs is more tolerated, so a woman is discriminated against. There is a difference. A woman cannot get any support. She will not receive any support, so she is shut out, but a man can be given work to do, heavy lifting, manual labor, stuff like that, but for a woman, it is difficult. Elaborated by this quote, family support is essential for methadone. The program requires that you do have a family member sponsor you that agrees to help with transport, room, and board. However, many women still face barriers to care.